Welcome to Care Transitions Today. I'm your host, Deb McElroy. This podcast is brought to you by the American Case Management Association. Join thousands of your peers who have made the decision to further the connections, learning, and knowledge afforded through ACMA membership. Gain access to the Member Education Center, a resource that includes a multitude of recorded webinars, continuing education credits, and peer-reviewed articles. It's available 24/7 and exclusively to ACMA members. To learn more, visit www.acmaweb.org/membership. One more time, acmaweb.org/membership to learn more. And now to today's episode. The pandemic has led to an economic downturn and associated increase in the prevalence of mental health problems globally. It considerably worsened the pre-existing crisis of unmet need for care. My guest today argues this presents a historic opportunity to reimagine mental health care and to scale interventions designed to improve the access, quality, and person-centered features of care. So we are doing today a special bonus episode, and I am delighted and honored to welcome Dr. Vikram Patel. Welcome, Dr. Patel. I am going to do a bio because I really want our listeners to know and understand the expertise you're bringing to us today. A few items on Dr. Patel. He is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow at the Harvard Medical School. He's a psychiatrist whose work over the past 2 decades is focused on addressing the vast unmet needs for mental health care, especially in low-resourced settings. He holds honorary professorships at the Harvard T.H. Chan School of Public Health, the Public Health Foundation of India, and the London School of Hygiene and Tropical Medicine. He is co-founder of Sangath, an Indian NGO which won the MacArthur Foundation's International Prize for Creative and Effective Institutions, and also received the World Health Organization's Public Health Champion of India Award in 2016. Dr. Patel is a fellow of the United Kingdom's Academy of Medical Sciences, and he has served on the WHO High-Level Independent Commission for Non-Communicable Diseases and Mental Health. And he's also served on other WHO and Government of India expert committees as well. He's based in India part of the year, and he has served on the government committee which drafted that country's first national mental health policy. Over the course of his career, he has co-founded the Center for Global Mental Health and the Mental Health Innovation Network at the London School of Hygiene and Tropical Medicine, the Movement for Global Mental Health, the Center for the Control of Chronic Conditions at the Public Health Foundation of India, and most recently, the Global Mental Health at Harvard Initiative. He's been recognized for his work and was awarded the Sarnet Prize by the National Academy of Medicine in 2014, the Pardes Humanitarian Prize by the Brain and Behavior Research Foundation in 2016, and the John Dirk Canada Gardner Award in Global Health in 2019. I wanted to take that time, Vikram. We're so delighted to have you, and welcome.
Well, first of all, thank you so much for that warm introduction. And thank you so much to the ACMA for inviting me to participate in your conference this year. It's just a great pity that we're not all sitting in person. And of course, for anyone who's involved with healthcare, I think we can all appreciate how dramatic the last year has been in terms of transforming the way we work with people that we care about and care for. And I think this is another example of how resilient our healthcare system has been in the last 18 months, in spite of the tremendous challenges that all of us have faced. I wanted to just maybe preface a little bit about the pandemic by just emphasizing what you said earlier, which is that our mental health care system, and by our, I mean everywhere in the world, including here domestically in the US, was already unable to meet the needs of our populations in terms of mental health interventions, both preventative interventions, but I guess more importantly, for people who already live with a mental illness, interventions that can promote their recovery. And it's important for me to emphasize that this was not because we don't know what works. Very often in the healthcare context, one reason why we can't reduce suffering is because we don't have effective interventions. This is not the case in the mental health sector. In fact, we have many effective interventions spanning the full range of medication, psychological interventions, and social interventions for a whole range of mental health conditions across the life course. The real challenge has been doing better with the knowledge that we already have, implementing in a more just and equitable way the knowledge that we already have. This has been the fundamental problem. Even before the pandemic, the US was spending more per capita on mental health care than any other country in the world. Of course, the US also spends more on healthcare more generally, but that includes a significant share that goes to mental health. And yet, if you look at surveys of access to quality care, the results do not measure up to the amount of money that's been spent. The results do not measure up to the number of mental health professionals. I know that we often think here in the US that we have not enough mental health professionals, but here's an important fact. The US, parts of the US, like for example, just New York State, has more mental health professionals than the whole of Africa. And that's something to reflect on, that we already have the most in the world. And the question we have to ask ourselves is, even before the pandemic, why were we not able to get better results given all that we spend on people and on a variety of other resources? And to me, therefore, the pandemic, because it marks in many ways a clear break from the past. For example, as I mentioned earlier, that we now have pivoted entirely or to a large extent to telehealth platforms for mental health care, it presents a historic opportunity to not only ask that question, but to really reimagine what mental health care should look like in the US going forward.
That's wonderful. And actually, I think eye-opening when you think about the resources that are there. So you're doing work on reimagining mental health care. The pandemic drew, I think, some attention to the mental health and substance abuse use among adults and children. And in fact, I saw a reference to really just the dramatic increase in children really suffering from mental health issues. But as you're just talking about, it seems like we're lacking that coordinated approach or maybe a consistent national approach to healthcare. So can you talk a little bit more about where you see progress, what learnings you think that we were able to achieve during the pandemic? And I guess the question is really, where do we go from here?
So it's first of all really important for us to emphasize that the burden of mental health problems is disproportionately distributed across the population. I think that's probably evident to almost anyone who works in the health sector, but it's important to emphasize this. And the effect of the pandemic has similarly been disproportionate across different subgroups in the population. And I think we all can immediately guess which groups have been hardest hit. Obviously, low-income populations more generally, but also from a life course perspective, it's young people. And I think we haven't given sufficient attention to the fact that most mental health problems begin before the age of 24, which means, and particularly during our youth, which is really around the age range from puberty up until our early 20s. This is, of course, we now recognize developmentally a very critical phase of the life course. This is the phase when most of the burden of ill health is due to mental and substance use conditions, including self-harm. But we haven't really, our mental health care system doesn't really fully address young people's mental health anywhere near as well as it should, given the enormous burden of mental health problems in this age group. I'm sure your listeners would be astounded to learn that not only is suicide and unintentional injuries, which includes a very strong mental health component, the leading cause of death in young Americans, but that in the last decade, even this is before the pandemic, by the way, those suicide mortality rates have increased by nearly 50% in young Americans. In addition, of course, one has to also count the substance use related mortality. This is over and above suicide mortality. So let's be clear that mental health problems don't only make an individual unwell and make them suffer, but it is also a leading cause of mortality, particularly in young people. So before we think of solutions, I think it's worthwhile asking ourselves the question, why, in spite of all the spending, in spite of the relative richness of mental health specialist resources that this country enjoys in comparison with any other country in the world, why is it that virtually every metric related to mental health or mental health disorders has worsened over the last 2 decades? And the pandemic has made it even worse. If you look at the latest data on the prevalence of self-reported mood and anxiety conditions and substance use over the course of the last year, you will see, particularly in young people, astonishingly high rates of anxiety, depression, and substance use. So the question is, what is broken and why is it broken? I think all of us have our own explanations for this, and these are the ones that I would like to suggest. First, I believe a key problem has been the very narrow binary framing of mental health in biomedical terms. The idea that we can classify people into a group of people who have a mental disorder and then subgroups of various disorder diagnostic categories and a group who don't, which is of course completely counter to the fundamental dimensional nature of mental health that neuroscience teaches us as a fact, but also in terms of how people in the community understand their own mental health. Most people don't understand their mental health as in a diagnostic way, as perhaps people might do for COVID-19. The second, we rarely fully acknowledge the coexistence of social determinants with mental health problems, either in our programs. So, for example, our programs for mental health care tend to only focus on the diagnosis or on the symptoms, oftentimes completely ignoring the social determinants that actually lead to these problems and also, importantly, lead to their perpetuation. And therefore, we also don't fully acknowledge the need for person-centered care that is tailored to the needs of disadvantaged individuals, particularly disadvantaged young people. We may have a lot of mental health human resources, but another challenge is that they're very inequitably distributed. They tend to be largely concentrated in the big cities of the country, but also they tend to be largely concentrated in the private sector, which often excludes, therefore, a huge swathe of America's people who live in rural or remote communities or in communities where there are large proportions of people who are low income. At the same time, we've disempowered resources that every community has. And I'm gonna emphasize that point because I want to return to that about where I think of reimagining mental health, the opportunities. But I believe that for now, it would be fair to say to a large extent, the biomedical framing of mental health has also meant the disempowerment of non-biomedical providers outside the health system as being engaged with mental health care. And finally, and I'd say this is particularly true for young people, there's a reluctance to seek help from mental health professionals. I think it would be fairly accurate to say young people are endowed, perhaps to their advantage, with a feeling of invincibility. But I think where this becomes a disadvantage is that oftentimes this delays help seeking when a young person is experiencing significant health problems. And of course, mental health problems are the most common, as I mentioned earlier. So I think we have to first acknowledge these challenges before we can begin to think about what are the opportunities for reimagining and transforming the US mental health care system.
So Vikram, when we talk about that, when we talk about acknowledging, what does that look like, sort of systemically in the US? Is that health systems embracing, a different approach throughout their healthcare continuum? Is it a higher level? Is it a higher national level policy issue? I mean, do you have some suggestions or thoughts on that?
Yeah, well, again, here I'm going to be speculative. I think there's certainly a lot of people who have been asking this question. I don't think there is a single answer, as you might imagine, to this very complex question. I think there are a number of different factors. I mean, the ones that I hear frequently from my colleagues who are at the front line, one of the key things is about how reimbursement policies are confounding the attempts to provide mental health care. By this, I refer to the fact that you have to have a diagnosis and then you have to follow a certain set of highly reduced sets of opportunities for care that the reimbursers, the insurers, will actually pay you for, which means that even things that you might think are important but don't fall into that basket of reimbursable goods will not be offered. And in this, I would include a whole range of social interventions. And another problem, of course, of this model is that you're forced to give a diagnosis in order to be reimbursed, even though perhaps a person may not want a diagnosis or even need one to receive a mental health care. That's one of the I think one of the major obstacles. Another one, of course, is territorial disputes. America is blessed, actually, with an incredible diversity of mental health professionals of different disciplines. But where I think there's a problem is that these different disciplines don't often see themselves as being part of a collaborative, coordinated team of providers. There tends to be turf and territorial issues, which often means that although on paper we have a large number of mental health specialists, they don't actually work necessarily and always as a coordinated group of providers. A third is, while there's a lot of conversation about empowering people in the community outside the mental health sector to be involved with mental health care, particularly for people with mild or moderate mental health problems, and also for continuing care. Unfortunately, there's very little resources that are being allocated at the base of the pyramid. The truth is, most of the significant amount of money that's being spent on mental health care is being spent on specialist providers. Very little really trickles down, in spite of all the talk, to people who are working on the front line in community context and primary care, etc. These are just some of the important challenges. And finally, I will say one more important challenge is the coordination of care. I think the idea that one size fits all, of course, we know is the one that is an idea that completely doesn't apply to the complex nature of mental health care, not only at the population level, but also the level of an individual. An individual's trajectory with their mental health changes over time. And this means their needs change over time. And this means that if we have to accompany a person across their life course to address their mental health, we need to have a seamless transition of that person according to their needs, from community supported care all the way to inpatient care. And that, unfortunately, also doesn't happen because of the fragmented nature of our healthcare system.
So and I'm going to reference something you said earlier. I think that is particularly resonating with some of the audience that we have today, who's, we talk to professionals whose scope and responsibility is around moving someone through a continuum of care in our current health system. And they're often having to do it quickly. They could be in the primary care setting within a physician's office, or it could be a hospitalized patient, it could be somebody moving in home care or in a skilled nursing facility. All of those folks have this mental health component that they need to address as they're coming up with to support a patient and their family in their plan of care. So I'm intrigued. I think the social determinants that you talked about earlier, and just that empowerment, these are all of the challenges that I think that you've surfaced that really resonate with the people that are listening today. And when we think about trying to be creative in our solutions, I'm just really interested to see what thoughts you might have as you're looking at someone moving through that system. So I know you have the Mental Health for All lab that is trying to leverage digital technology. Obviously, telehealth in general kind of was highlighted as we went through the pandemic. So I guess I love to hear about some of that work and some of the advancements that the folks that are doing this job of coordination, that they can embrace.
Absolutely. I think what I'll do is I'll actually describe what I myself am engaged with here in the US. And here I want to just emphasize that a lot of my work in the US has been heavily influenced by my work in low resource communities outside the US, particularly in South Asia and Sub-Saharan Africa. And this is a unique opportunity for us in the US to actually learn on how people in much more difficult and less resource contexts have been struggling to try and meet the mental health needs of their populations. Typically, these are places, as I mentioned earlier, which have almost no specialized resources for mental health, either inpatient resources or outpatient resources in terms of community-based mental health providers. So, I'm gonna really describe what I'm doing here in the US as an illustration, really, of how we can learn from the world.
Perfect.
So the first thing I think is to look beyond narrowly defined mental illness. And this requires us to explicitly engage with and work with the insurance industry, which forces us to apply diagnostic labels in order to offer care that can be reimbursed. This, I think, is a very major challenge. It requires an active engagement with, obviously, state and federal authorities that are concerned with publicly financed mental health care, but equally with the insurance industry that reimburses providers, so that we can offer care without necessarily a person reaching a degree of clinical severity that then requires a diagnosis. It seems counterintuitive when you think about it, right? That we have to wait for someone to become so ill that they become a case before we can actually provide care. It completely runs counter to everything we've been taught about early intervention, about prevention before a person becomes significantly ill. So that's the first important principle. And of course, this not only captures the dimensional nature of mental health, but also is completely in line with the continuum of care that we need, that I mentioned about earlier. Second, that if we think about the continuum of care in a pragmatic way, it means that we must strengthen the base of the pyramid of care. By this, I mean care that can be delivered in community contexts outside the health sector or as an extension of the health sector. I'm pretty sure that many of your listeners who work with inpatient settings will remember that one of the most challenging aspects of caring for people with mental health problems, and here I include substance use problems, is the repeated relapse of individuals soon after they have left hospital. And we all also know what the reason for that is. That is because typically, the continuing supportive care that they need in the community that is connected with the inpatient facility is missing. And that's one example of how we can improve the overall health outcomes of people with mental health problems by really building the foundation of community care so that we can meet people with mental health problems where they are, rather than wait for them to relapse and come to us. The third is that, continuing from this notion of building the foundation of the community of care, is that the care pathway must focus on early interventions, both early interventions for prevention of further escalation of existing psychological distress, but also early interventions to prevent relapse of established mental health problems which have recovered following inpatient care, as I mentioned earlier. And this is where I want to really emphasize what the world can teach us. And this is that with adequate and carefully designed training, typically competency-based training, the use of brief interventions that are demonstrated to be effective in improving mental health across the full range of different mental health conditions, frontline workers such as social workers, community health workers, community-based nurses, peer support workers, etc., can act effectively help people with mental health problems recover or stay well. And I think this is a really powerful piece of science, implementation science, which is transforming the way we think about mental health care in the US. I wanted to just alert your listeners to, I think, a very important report that has just been published by the RAND Corporation, which I think many of you will be familiar with. Is a very well thought of think tank in the US. The report is titled How to Transform the US Mental Health System. And these are precisely the recommendations that the RAND Corporation report speaks to. And I'm going to actually paraphrase what the report says. Communities should be equipped to provide a well-coordinated, I want to emphasize that word, a well-coordinated and evidence-based continuum of mental health services to meet the needs of people with mental health problems. And they advocate as a critical approach to achieve this, the training of community-based non-specialist providers so that much of the mental health care that is needed in the community is delegated to these providers, while specialists are therefore able to allocate their time to work at the top of their license.
I think what you just summarized is so powerful as you're thinking about those community resources, and you alluded to the escalation in the young population and being able to identify healthcare issues prior to age 24. I'm assuming maybe resources even within schools. And I mean, it's not like we haven't had that, but in addition to some of the folks that you're talking about, we could really strengthen the bottom of the pyramid with existing organizations that have some resources, but maybe need more competency-based training.
Absolutely. I mean, I think with young people, I will say one more thing. You're absolutely right. We need to meet young people where they are. Young people do not like to come to hospital. They do not like to see doctors. They do not like to see health professionals, period. And, we've known this for, as long as we've studied young people's health. And by the way, this is not only true of mental health. This is just generally true. Ask anyone who works with young people who have type 1 diabetes, they'll tell you the same thing. So I think we need to understand the unique developmental characteristics of young people if we have to design services that are actually sensitive to and tailored to young people's needs. And within young people, we also, I want to emphasize again, recognize the diversity of young people. Young people who belong to the LGBTQ plus, section of our community will obviously need also even more tailoring to make sure that mental health services are sensitive to their needs. Young people who belong to historically disadvantaged or minority communities similarly will also need culturally appropriate services. But as a general group, we need to meet young people where they are. That translates into services that are accessible, for example, in educational institutions, services that are accessible through through the digital media, which of course is a very powerful medium for young people in particular, and services that are led by, which involve delivery by, and are held accountable by young people. And this is the point I wanted to emphasize. For young people, more than any other demographic in society, there is a sense, nothing about us without us. The last thing that young people want as they make the transition from being fully dependent kids to being fully autonomous adults is to be patronized, to be told what they need, and to be told what they should do. And I believe that as we think about reimagining mental health care, particularly for young people, we need to also reimagine who is in charge. And I think this requires us to hand over some power to young people themselves. And I believe through my own experience, particularly in the global context, when you do that, you deliver services that are far more sensitive, that are far more resonant with what young people themselves want and expect.
Do you have any examples of either with the youth or overall of initiatives that you've worked with in other countries that did just that scaled up that kind of training and delivery within a community?
Absolutely. I mean, I'll give you examples both from a high resource setting as well as low resource. By the way, this is also happening in the US. There are actually enormously innovative examples of challenging the orthodoxy of mental health care in the US. And I want to emphasize that, the problem is that there isn't adequate resources backing these for scale up. That's the problem. We're not short of innovators. We're not short of people who think out of the box. We're just short of the political will, which is changing. By the way, it's changing now, and I'm really thrilled about that. We're just short of actually money to integrate these relatively discrete, small-scale demonstration or community-based pilot projects into something that can become part of an integrated mental health care system that's fully integrated with hospital care. But two examples of work from the global context. The first is in Australia, the Origin program, and associated with that is a network of drop-in centers for young people, which are led by young people in a variety of different roles. For example, the stewardship of the centers. I'm going to try and remember what the name of the center is. It's just eluding me, but the program is organized by this initiative called Origin. And essentially, they're drop-in centers which provide one-stop services for young people. This is not only mental health, it's not also only health, but a variety of other services addressing social determinants of health. For example, finding employment, etc. And the provision of care is fully integrated. So both physical as well as mental health care needs are being addressed holistically. And this is another really important perspective, which I think we should begin to acknowledge is central to improving access to good quality mental health care, is to make sure that people don't have to go to multiple providers for other healthcare needs that are deeply interconnected with mental health. In India, I've been working extensively in educational institutions, particularly in schools and colleges, to modify the social environment of these institutions so that these can become mental health promotive. And the key individual who acts as a facilitator to coordinate these interventions to build, for example, school climate, which is a sort of perception that young people have about the peer relationships they enjoy, about the relationships they have with their teachers, are usually young people themselves from the local community who have just completed their educational career. And in fact, this is, of course, a dual strategy. Not only does it strengthen the mental health promotive aspects of educational institutions, but it also offers jobs to young people. And so, it's a double strategy, and particularly relevant right now, where youth unemployment is also a matter of significant concern. Here's the interesting idea. We can turn the pandemic into an opportunity in two ways. First of all, by reimagining how mental health care should look in all the ways I've suggested, but also by increasing the role of non-specialist provider, creating completely new skills-based pathways for employment for young people today.
Well, that's awesome. So I know that you're involved with, there's an interdisciplinary global mental health initiative at Harvard and with Sangath. And can you talk a little bit about that? Can you talk about the progress? Because it sounds like that's woven into the what you're talking about.
Absolutely. So Global Mental Health at Harvard was launched exactly 3 years ago, 1 year of which has been pretty much wiped out by the pandemic, although we've used it in very, very effective ways. And I want to tell you about that in a moment. So it's really an initiative that's a cross-university initiative that seeks to harness the incredible scholarship that Harvard has had across many different perspectives of mental health, not just the one, not just clinical, not just neuroscience, not just social sciences or the humanities, but across these different disciplines to harness all this incredible scholarship to work in an interdisciplinary way to realize the goal of mental health for all, to realize the goal of doing better with the knowledge we already have, rather than constantly being nihilistic about the state of the science, by being, pessimistic about what we can do with the current state of knowledge. I believe we can do a lot more. And I want to give you a few examples of the activities that Global Mental Health at Harvard identified and is now taking forward, and particularly talk about the application in the US. So I mentioned repeatedly, of course, building the base of the pyramid, right? I mentioned repeatedly the strong science that exists about the effectiveness of non-specialist providers working in non-healthcare settings to deliver both clinical interventions for enabling recovery, but also preventative interventions. Well, what's the obstacle for that, to scale that up? The key obstacle is training and supervision. How do we train this large army of providers that we need in these clinical interventions? How do we supervise them in ways that can build their capacity so they can master these interventions? And how do we assure quality in the long term? And how do we ultimately coordinate this frontline worker with the specialists who work in hospital settings? These are all the fundamental implementation challenges that we have to address. So at Global Mental Health at Harvard, we've launched a number of initiatives to actually enable this to happen in the US. And I want to just talk about three very briefly. The first is Empower, which is an initiative that uses digital tools like learning management systems and digital tools for supervision and for quality assurance to help build the workforce to deliver evidence-based brief psychosocial interventions. And the great news is, along with colleagues led by the Meadows Mental Health Policy Institute in Texas, we just won the Lone Star Prize, which is a $10 million prize to scale up depression care in underserved communities in Texas, building on everything I've just said. Coordinated collaborative care that connects behavioral specialists with primary care, with community providers who will be trained in brief psychological interventions for mild to moderate depression. We also obviously are going to use the Empower platform for a number of other things, but in the interest of time, I'll move on to the other activity. The second activity is called Champions, and we're here looking forward to collaborating with the American Psychological Association to build an executive education program for people, as it were, at the other end of the pyramid, people who are organizing, financing, leading mental health programs at a population level, so that the principles that I talked about earlier, the coordinated collaborative care principles with a frontline worker force, can actually be implemented. How do you finance this? How do you coordinate this? How do you hold it accountable? And the third piece is called Countdown, which is developing a set of metrics that one can use for a mental health care system to evaluate its performance, not only over time, but also with other mental health care systems, for example, in the US, to look at which systems are doing well, which systems are underperforming, using the same set of metrics, and then interrogating what makes one system work better than the other, so that we can learn from each other. For me, this is the most important next step, is for us to have a sort of almost a national a learning collaborative in which mental health systems can learn from one another. For that, what we need, of course, is a common set of metrics that everyone will be using.
So I'm listening to you and thinking about some of the folks in our audience, and congratulations, by the way, in Texas. We're going to have you come back and revisit us and tell us, some of the wonderful results you'll get from that program. But I'm thinking about some of the case managers who are like, this is exactly what I need for from a hospital perspective, or somebody, a physician in the primary care office saying, yep, I can envision somebody that I need to interface with that kind of community program. So suggestions on how you get some of these really wonderful community-based programs visible to the more structured healthcare system that folks are also, accessing, so that it is coordinated.
I think the most important place to start is amongst ourselves. Those of us who are health professionals have to actually broaden our own perspectives of what healthcare should look like for the average American. And that involves us not only embracing the science of implementation of community mental health care, acknowledging it first, embracing it next, and then advocating for it. Change has to happen not only from the bottom up, but also from the top down. If there is resistance or if there is lack of interest, then the resources that are needed to actually support the growth of the community-based workforce will not happen. Let's be honest. Power lies in the hands of the healthcare providers, healthcare professionals. And by power, I mean not just decision-making power, but also the money that is allocated to the healthcare system. I think it is a wake-up moment for us. Because if you look at the language of all the new federal and state level mental health care initiatives that have been announced since the pandemic broke, you will see certain words, certain ideas recurrently occurring across all of these. And they are about building non-specialized community-based workforces, whether they use terminologies like peer support workers or community health workers. They may use different words, but they all mean the same thing. And the RAND Corporation, which is, not exactly a corporation that has previously worked in the sector in any extensive way, their report actually speaks to exactly the same playbook. And I think we need to all, in the health sector, recognize the winds of change that are shifting our perspectives of what America's healthcare systems look like. And by the way, this is not only for mental health, but of course, mental health is the exemplar, partly because the metrics that I mentioned earlier are so disappointing, really. Let's be honest, for all the money we spend on mental health care, we should get a far better result than we currently have. This is a very unsatisfactory situation, and that's putting it mildly. I think what we must demand is change, and change must come from within ourselves first. And that must begin by acknowledging that there are others outside our narrow or small group of providers who are also very important agents of change, very important members of a diverse workforce for mental health care.
Yeah, I hear standing ovations from our audience, certainly from me. I think it is truly a shift in thinking. And so I know we have just a few minutes together left, and I would just ask you, I think you've articulated so beautifully where we need to head. And I guess just for you personally, having worked in this for so very long, what is your, immediate dream? We're headed to post-pandemic, and there is some shifts. So, again, I think you beautifully articulated a new model, but what does it look like if you feel like, okay, we're there, we're getting there?
So I want to end with an aspirational, statement. For me, after 2.5 decades as a psychiatrist working with disorders and treatments, I believe I'm personally at that juncture where I want to reframe mental health not just as a biomedical concern, but truly as a public good, both at a national level, but at the global level. Because if you pause and think about what mental health means, in my mind, it is my greatest personal asset. It is in many ways far more important than any physical attribute that I have. And this is one of the reasons why mental illness is often most feared as well, because actually, implicitly, we value our mental health immensely. It's a universal human quality. It's important to each and every one of us at every given point in our lives, not only when we have a mental illness. It's indivisible from our physical health. And I think one of the great, one of the great sadnesses about modern medicine has been the splitting off of mental health, literally in every way, in the way, we provide care, where we provide care, how we finance mental health, who provides mental health care. In every respect, the splitting of mental health and physical health, I think, has been to the disadvantage of ordinary people. And I think in reframing mental health as a public good, I would also emphasize the full integration of mental health in all aspects of healthcare. We need to recognize also, as we reframe, that mental health, while it is important to everyone, it's also something that is disproportionately enjoyed across the population in terms of good mental health. And I think we need to acknowledge the unique needs of low-income populations that are historically disadvantaged, and young people as a demographic. And finally, we need to grasp this historic moment. It won't come again. I hope it doesn't come again. I hope we don't have another pandemic, at least in my lifetime. This is truly a historic moment for us to make the radical changes that we have felt for so long we needed to make. This is the moment. This is a chance for us to really leverage the political will and the resources that are being committed towards transforming mental health care in the US.
Well, that beautifully said. And I think that that's a great place to leave our listeners thinking. Just in our short time together, shifted my thinking, and I'm sure that's true for our listeners as well. Dr. Vikram Patel, thank you so much for being with us today. We look forward to having you again sometime. If you've enjoyed listening to this podcast, please leave a rating and a written review so we know what you think, or give us some ideas on topics you would want to hear about. Until next time, thank you for listening.